Good afternoon and welcome to Basics of Hemophilia. Thank you for joining us today. My name is Jasmine Palderai and I am an education specialist at the National Hemophilia Foundation. Before I introduce our speaker today, I wanted to go over some tips and tricks to get the most out of this virtual session. Firstly, you'll notice a chat box over to the side. This is where you'll be placing your questions and comments throughout the session. Our speaker will be in the chat answering questions for the duration of the presentation. We will also have a couple minutes at the end of the presentation to ask any further questions. You'll also notice a feature titled Ask a Follow-up Question. These questions will be emailed to the speaker and she will respond at a later time. Please utilize either of these resources to ask your questions. Lastly, this session will be recorded and available to watch at any later time. Now it's my pleasure to introduce you to our speaker today. Sue Garrity has an Associate of Arts degree in nursing from Lander College, a Bachelor of Science degree in nursing from University of North Carolina at Charlotte, and a master's degree in business from University of Colorado, Denver. She has over 40 years of experience as an RN, most of those spent in orthopedics and bleeding disorders. She worked as a nurse coordinator at the University of Colorado, Denver Hemophilia and Thrombosis Center for 25 years, where she retired in 2013. Currently, she is working as an independent consultant in the areas of bleeding disorders and healthcare education. Sue, we're happy to have you here with us.
Thanks, Jasmine. So this afternoon, we're going to talk about the basics of hemophilia. Some of you who are listening may be new to the hemophilia community, while others may have been part of the community for a number of years. My goal is that you all take away at least one new piece of information from this talk this afternoon. These are my disclosures. So what are our objectives for this afternoon? We're going to review hemophilia and understand how it's passed on, identify the types of bleeding, including signs and symptoms, discuss prevention and the management of bleeding, and then we're going to go over a few tips at the end of things that you should be aware of in dealing with your child with hemophilia. So let's start out by talking about what hemophilia is. There's an overarching umbrella of the term hemophilia, but most of the time it includes patients with hemophilia A and hemophilia B and some of the rare types of factor deficiencies. Hemophilia A is factor VIII deficiency. It's sometimes referred to as classic hemophilia. It's 1 in 5,000 live births, and it is an X-linked inherited disorder. What that means is it's carried on the X chromosome, which is one of the sex chromosomes. So we have 23 pairs of chromosomes, plus we have an X and a Y that determine our sex. Girls get 2 X's, boys get an X and a Y. So this is carried on the X chromosome. 70% of patients have a family history of hemophilia, meaning that someone else in the family has had this disorder. Not the other 30% are what we call a genetic mutation, which means that change in the X chromosome either happens in the mother as a carrier or in the child as an affected individual. We'll talk more about that here in a few minutes. The hallmark sign of hemophilia is prolonged bleeding, and 25% of patients with hemophilia A will develop what we call an inhibitor or an antibody against infused clotting factor. This is more common in our patients who are African American or who are Hispanic. Hemophilia B is the second type of hemophilia that we refer to. It's factor IX deficiency and is sometimes called Christmas disease. It's not named after the holiday. It is named after the first patient identified with factor IX deficiency, Stephen Christmas. It is 4 times less common than hemophilia A. So for every 4 hemophilia A patients that are out there, there's only 1 hemophilia B patient. Like hemophilia A, it is also an X-linked inherited disorder and affects 70% of patients have a family history and 30% do not. And again, the hallmark sign and symptom of hemophilia B is prolonged bleeding. Unlike hemophilia A, only 5% of patients with hemophilia B will develop that inhibitor or the allergy, or so to speak, to hemophilia factor, infused clotting factor, whereas 25% do in hemophilia A. The difference is those in hemophilia B who develop this actually can have a true allergic reaction when they develop that inhibitor. The other factor deficiencies that often fall under the umbrella of hemophilia are factor 1 or fibrinogen, and the lack of that is called afibrinogenemia. Factor 2 is prothrombin. Factor 5 is extremely rare, not to be confused with factor 5 Leiden, which is a prothrombotic or a clotting disorder, which is fairly common. This is factor 5 deficiency. And in my 40 plus years of nursing, I've only seen one patient with factor 5 deficiency. Factor 7 deficiency is a little more common. The patients who have severe factor 7 deficiency actually exhibit signs and symptoms similar to factor 8 and factor 9 deficiency. Factor 10 and factor 13 are both extremely rare, and factor 11 is often referred to as hemophilia C and affects people of Ashkenazi Jewish descent. So most of the people with hemophilia C or factor 11 deficiency have some Eastern European history or family history of bleeding in their family tree. Not all. There are a few hemophilia C or factor 11 deficient patients who are not Jewish. Here are two typical scenarios of the inheritance pattern of hemophilia A and hemophilia B. On the left-hand side of the slide, you will see the woman is a carrier, or the mother is a carrier of hemophilia. She has two X's. One of her X's carries the hemophilia gene, the other does not. And her husband or significant other, whoever, has an X and a Y, which indicates that he's a male. With each pregnancy, the father will give either his X or his Y, and the mother will give one of her X's to the baby. If the mother gives her X to a male child, the dad will give his Y. That's what determines he's a male. But if he gets that X that carries the hemophilia gene, that child will then have hemophilia. If a little boy gets mom's X that does not have the hemophilia gene, he will not be affected by hemophilia. The same is true for girls. If mom donates her X that has the defect on it, that daughter will in turn be a carrier, just like mom. If the daughter gets an X that is not affected, then she will not be a carrier and will not pass hemophilia on to her offspring. Then we have that little boy with hemophilia who grows up and he gets married. All of his X's carry that hemophilia gene. None of his Y's do. So, and we're going to assume he marries someone. There are rare cases where someone with hemophilia marries a carrier of hemophilia, but we're not going to go there right now. But if the dad, all of his X's have hemophilia, and mom, none of her X's do. So she's going to give an X to a baby boy, and dad's going to give a Y, and none of dad's sons will be affected by hemophilia. However, dad's going to give his X to all of his daughters, and that X carries the hemophilia gene, and so therefore all of his daughters are going to be carriers of hemophilia. And that will be a carrier of the same type and the same severity as the dad has. So for example, if dad has severe factor 8 deficiency, the daughter will be a carrier of severe factor 8 deficiency. And then, as I mentioned earlier, 30% of patients have no family history, and they are what we refer to as a genetic mutation. And that mutation can either occur in mom as a carrier or in the baby as a son with hemophilia. How is hemophilia diagnosed? Well, it's a little different if you have a family history versus no family history. If you have a family history, prenatal diagnosis or diagnosis in utero is possible. It can be done two ways, through amniocentesis or through chorionic villus sampling. These procedures do carry a 1% risk of miscarriage. And you really do need to know the mutation that exists in your family. So if there's a living relative, or if the mutation has been identified in the past through My Life Our Future or through your HTC, and we know that mutation, we can do this chorionic villus sampling and amniocentesis and see if the baby has that same mutation, thus determining whether or not they're affected. If we know mom is a carrier, but we don't have the mutation, or if the family has elected not to do an amniocentesis or CVS pre-delivery, once the baby is born, cord blood can be obtained in the delivery room and sent to the laboratory, and factor 8 or factor 9, depending on what the deficiency is in your family, can be performed on that blood sample and determine whether or not the baby is affected. This can also be done at a later point in time, but many women who are carriers of hemophilia want to know right away. If there's no family history, however, typically we find out that the baby's affected because they're having bleeding. About 50% of male infants in the United States are circumcised, and when a baby with hemophilia is circumcised, they may, but not always, continue to bleed. The other type of bleeding we see in infants or newborns comes from the heel stick that's done. All babies are going to have a heel stick done, and this is because there's some mandatory genetic testing that's done at birth. And if you get a heel stick that continues to ooze, then that's a sign that there possibly may be something wrong with the baby in terms of bleeding, because they're not able to clot. Having a combination of both the heel stick and a bleeding circumcision will definitely lead you down the path of looking for something else. Initially, a screening test is done, and if that test is prolonged, then something called a mixing study is done, and then we start down the path of looking for specific factor deficiencies. First, if there is no family history, we're going to look for factor 8 deficiency, because, like I said earlier, it's 4 times more common than factor 9 deficiency. So when we start talking about how having hemophilia impacts bleeding, let's look at what's considered normal. So those of us who are not affected by hemophilia have a factor 8 or a factor 9 level between 50 and 150%. And this is dependent on the laboratory where the testing is done. Patients with mild hemophilia have between 5 and 40% circulating factor 8 or factor 9. And those patients really only bleed with significant trauma, with a challenge such as surgery or dental extraction. Patients with moderate hemophilia are those who have between 1 and 5% circulating factor 8 or factor 9. And those patients can bleed with more minor trauma, but typically do not exhibit spontaneous bleeding. Whereas those patients with severe hemophilia, less than 1% circulating factor 8 or factor 9, can have bleeding with all of the things I've mentioned before, surgeries, accidents, things like that, but they also can bleed spontaneously without a reason. So let's reflect on what happens when an injury occurs to a blood vessel. And this can either be a blood vessel where someone is bleeding externally or someone is bleeding internally. Normal clotting takes place when there's an injury to the blood vessel. The first step is that the blood vessel wall shrinks, or something we call vasoconstriction. And that tries to decrease the amount of blood that's going to the hole in the blood vessel. Then our body sends platelets, which is another cell that circulates in our blood all the time, and those platelets congregate at the side of the hole and plug it. Then the factors, including factor 8 and factor 9, as well as von Willebrand's factor and some of those other factors that I talked about at the very beginning, all rush to the site and make a net over that plug that holds it in place until healing takes place. So the top panel depicts what I just talked about, what happens with someone who does not have hemophilia. This is normal clotting. And you can think about it as a series of dominoes. They all fall, and in the end, they cover up the hole and the bleeding stops. But what happens in hemophilia? If you look at that lower panel, you can see the vasoconstriction takes place. Platelets go to the site of the injury, but they're unable, because we're missing factor 8 or factor 9, to make that net that holds everything together. And so the patient continues to ooze or bleed from that injury in the blood vessel. Keep in mind, however, patients with hemophilia don't bleed faster than anybody else. They just bleed for a longer length of time. But we don't want our children with hemophilia to bleed. So how can we prevent bleeding in our patients with hemophilia? For those patients that have severe hemophilia, they are typically offered the chance of prophylaxis, or giving factor preventively so that bleeding does not occur. This is regular factor infusions on a scheduled basis to prevent that bleeding. This can be done either with plasma-derived factor concentrate or with a recombinant, a genetically engineered factor concentrate. You will have this discussion with your healthcare provider to determine what's the best clotting factor for your child. There is now on the market today a non-factor therapy that is used for prophylaxis or to prevent bleeding. This is only available for those patients with hemophilia A. However, products are in clinical trials for both hemophilia A and hemophilia B. So soon we should have another product that is a non-factor product that can be used as a prophylactic agent to prevent bleeding. So what is this non-factor prophylaxis in patients with factor 8 deficiency? The one that is licensed in the United States currently is called emicizumab, or Hemlibra. And if you think back to those dominoes I showed you where you had that hole where you couldn't complete the clotting cascade, this particular product actually bridges between factor 9A and factor 10 to make a clot, and that's what we need it to do. So you can see here that it actually joins these two, factor 9A and factor 10, and this emicizumab brings those two together, and then we have a prevention of bleeding. Keep in mind, as I said before, this does not work for factor 9 deficiency. This product was initially released in the United States in 2017 for patients who have inhibitors, that antibody against factor, and in 2018 was released for all patients with hemophilia A deficiency. This is a little different than factor. As most of you know, factor is administered intravenously or into a vein. And this particular product is not given in a vein. It's actually given subcutaneously or under the skin like a diabetic would use insulin. So it makes it easier for families to be able to administer this product at home. Again, you want to have a conversation with your healthcare provider to determine if this particular product is something that may be available to your son or daughter. Not everyone is on prophylaxis. Patients with moderate or mild hemophilia may be on prophylaxis, but not all are on prophylaxis. And our women who are affected with mild hemophilia may also not be on prophylaxis. These patients are considered to be treated on demand or when a bleeding episode occurs. We encourage patients to get treatment within 2 hours of the recognition of a bleed. And This is 2 hours from the recognition. Those of you with very young children may not know that your child has a bleed going on. You may put them to bed thinking they're perfectly fine, and when they wake up in the morning, or they may wake up in the middle of the night, they're irritable, they're not moving an extremity. That's when you recognize that they're having a bleed. So we really encourage you to get treatment from 2 hours of recognition. The length of treatment a patient who is treating on demand will need is dependent on where the bleed is and how significant the bleed is. So again, you're going to have that conversation with your healthcare provider, your hemophilia treatment center, and they're going to help you determine what that length of time is. So what constitutes a bleed? Joint bleeding or hemarthrosis are the most common bleeds that happen in patients with hemophilia. This is bleeding into any joint in the body. However, the most common joints that are affected by bleeding are our knees, ankles, and elbows. And these are oftentimes referred to as index joints. But anywhere where two bones come together and there's a space, a joint space, bleeding can occur. We're going to talk a little bit about muscle hemorrhages. We're going to talk about soft tissue, life-threatening bleeding, and then the types of bleeding where we actually see blood. What are the signs and symptoms of bleeding? How are you going to know that your baby has a bleeding episode going on? You know your child, whether it's an infant, a toddler, or a school-age child, you know your child better than anyone else. So if your child is having uncontrolled bleeding, is in a bad mood, is irritable, that could be a sign or a symptom that the child is having a bleed. If your child is having difficulty moving in an affected area, for example, if your child is a toddler and has already learned to walk and all of a sudden has reverted to crawling, perhaps they're having an issue with an ankle. We look for swelling, and you want to compare one joint to the other one. You want to look at both knees. Is one more swollen than the other? Feel the joint. Is it warm to the touch? If your child is verbal, ask them if they have any numbness, if they can feel you touching them. And sometimes a very late stage may be that we actually see redness appear on the skin over the area where it's bleeding. And obviously, if you have overt bleeding coming from your mouth, your nose, or whatever, you're going to know that something is going on. As I mentioned, joint bleeding is the most common bleed that we see in patients with hemophilia. And in today's day and time, we really want to prevent joint bleeds. When I started in hemophilia, we accepted bleeding, joint bleeding, as part of what hemophilia was. Today, we really don't accept that. We don't want children born today to have joint bleeds or to experience this. But when it does happen over a period of time, it can result in hemophilic arthritis. Repeat bleeding can cause the cartilage between the bones to break down and may cause limited mobility or no mobility at all. So for those of you who are listening who have older family members, maybe a grandfather, an uncle, a great uncle, someone who has had multiple bleeds into a joint before the age of prophylaxis, you may see that they have some significant difficulties moving a joint. Muscle bleeds are significant because our muscles are encased in something called a fascia, and that fascia does not swell or does not expand. It's not elastic. And so when you have a bleed into a muscle, eventually that muscle tissue is going to fill with blood, the fascia is going to be full, and then it's going to put pressure on the actual muscle tissue and can cause the muscle tissue to actually die. Muscle bleeds can occur after falls, they can occur after vaccinations, significant trauma like a motor vehicle accident, and sometimes we don't even know why a muscle bleed starts, because it's not as easy to determine, oh, I picked this heavy item up and now I have a muscle bleed. But again, just like with the joint bleeds, early treatment is optimal and it helps avoid any complications. These are a couple of pictures of a young child with soft tissue bleeding. I want to bring attention to this area on this young man. These are what we call fingerprint bruises. They're very common in children with hemophilia. And these are soft tissue bruises. They don't often even require treatment, but sometimes they do lead to people wondering if your child is being abused. So you want to address this with your HTC and have a plan in case something like that should happen. And the social workers at the HTC are very helpful in coming up with a plan for you for that. Life-threatening bleeding includes head trauma, intracranial hemorrhage, bleeding in your brain. Some of the signs of this can be nausea, vomiting, headache, drowsiness, confusion. You may actually even eventually lose consciousness. The problem with intracranial hemorrhage is we can't see blood in a brain. I could be having an intracranial hemorrhage right now, but you can't tell that I'm having one. So we have to rely on these symptoms that are listed here, as well as doing something called a CAT scan or a CT scan. That helps us look inside the brain and see if bleeding's taking place. Sometimes, especially in those kids with severe hemophilia, there may not be a cause, or you may not know the cause. You know, you can have a kid who bumped his head on a swing and doesn't even think anything about it, but in certain circumstances, that could be enough to cause an intracranial hemorrhage. Anytime we have bleeding in the neck or the throat area, we get concerned because we need to have an open airway. We need to be able to inhale through our nose and get that air down to our lungs. And if that passageway between our nose and our lungs becomes constricted, it makes it difficult to breathe. Bleeding in pee or poop is not normal in anyone, and especially in a child with hemophilia. So you need to bring that to the attention of your healthcare provider immediately. And then the last one that's considered a life-threatening bleed is actually a muscle bleed, and it's in the iliopsoas muscle. It starts at your low back and goes around your hip. It's often what guys call they had a groin pull. And it can be confused with a hip bleed. The problem with this particular muscle is you can put a lot of your blood supply into this muscle and become anemic before it will eventually stop bleeding. Anytime you see blood, it's going to be obvious. Mouth bleeding is very common, especially in young children when they're first learning to walk. Nose bleeds, cuts or minor scrapes can bleed. And for those women who have mild hemophilia or even more severe hemophilia, heavy menstrual bleeding can be an issue. And there are medications that can be given for that, as well as factor replacement. So what are the likely bleeds that you're going to have at some of these stages? Obviously, an infant, initially they're not moving, they don't hold their head up, they're not even rolling over. So we're going to really have to do something to this baby to make them bleed. As I mentioned at the beginning of the program, circumcision is oftentimes the first bleed that a baby, especially those with severe hemophilia, have. Oftentimes babies will get bruises like those fingerprint bruises I showed you from handling. We pass a baby off to an older sibling or a well-meaning grandparent and say, now hold the baby tight, and if they hold them too tight, that results in those fingerprint bruises. Some of the key issues for you as parents or caregivers are this is a time of heightened anxiety. And it doesn't matter if you have a family history of hemophilia or not. This is your baby, and this is really, having a diagnosis of hemophilia can be very anxiety provoking. And you also will feel insecure. Are you going to be able to take care of this baby? And those are all normal, natural feelings. And you can talk to the nurse at the treatment center, the social worker at the treatment center, and then they can help reassure you that these are normal feelings and things you should expect. So you've had this little baby and he's not been moving around, and now all of a sudden they're crawling, they're learning to walk, and they're starting to fall. And these are the activities that typically cause toddlers to bleed. Oftentimes, this is when a child gets their first mouth bleed. They're learning to toddle around, they fall, they bite their tongue. They have those 2 front teeth or 2 bottom teeth, and when they fall, they bite through their tongue or tear the little piece of skin between their upper lip, and that's called the frenulum, and that can bleed excessively. And so now that whole increased anxiety starts all over again. You kind of mastered it when your baby was not moving around, and now you have an exacerbation of that anxiety because now there's a whole new set of things that can happen to your child. And this is a time when we work as healthcare providers with you to help you learn how to evaluate bleeding episodes. School-age children, it's a whole new environment when they go off to school. They may have been fine playing in the neighborhood. You had some control over who they played with and what they were doing, but now you send your child off to school, to kindergarten or first grade, third grade, whatever, and it's a new environment. There are new challenges. The kids are trying to keep up with their peers. They want to start participating in sports. So these are all likely activities that can lead to bleeding episodes. For parents, your anxiety goes up the first time your child wants to be away from home, whether it's at sleepovers or at camp. During this time with the pandemic, most camps have been canceled or have gone to a virtual format. If you have a child that's camp age, I encourage you to have them participate if your chapter or local area is having a camp, to participate in that camp. They'll meet other kids with hemophilia. And during this NHF bleeding disorders presentations, there is a virtual camp going on. So we encourage you guys to look into that if your child is camp age. Children that are school age often feel like they've done something wrong when a bleed occurs, and they need to be reassured that it's okay to have a bleed, that they didn't do anything wrong. And this is also the time where children learn to self-infuse. And again, I'm getting my plug in for camp because I think this is the best time that motivates kids. So hopefully by next year, we'll be able to resume face-to-face camps. And if you have a camp age child, they will really benefit from participating in some of the activities there. What are the other things we need to consider? Sports. As children grow up, and some of you parents out there may have participated in sports and were hoping that your child would follow in your footsteps. We really encourage physical activity. We want kids to participate in sports. We want them to be active. We know that if they're active, they will develop good, strong muscles and joints, and thus they actually have less bleeding, not more bleeding. Participating on a team sport especially can improve self-esteem, or participating in an individual sport where they're competing with themselves and have success can often also boost self-esteem. NHF has a great publication. It's called Playing It Safe. It was put together by the physical therapist in our community and really outlines what are the safest activities for children with hemophilia, what are moderately safe activities, and what are more risky type activities. Obviously, it's a no-brainer. No contact sports such as swimming, biking, golf, tennis are going to be the things that we recommend the most. We do try to discourage contact sports, but that said, it doesn't mean you can't have your child participate in some of the more risky sports. What it means is you have to have a dialogue or a discussion with your healthcare provider Adjust your child's treatment plan in order for them to participate in the sport that they would like to undertake. Again, traveling. Very few people are traveling in this time of a pandemic, but eventually we are going to get back to traveling and would really appreciate from a healthcare or a health HTC provider perspective that you contact the local HTC where you're going. I was in Colorado. A lot of people came out here on vacations, both in the summer and the winter. And oftentimes either they would or their home treatment center would call and let me know that they were in the area. I kind of consider this an insurance policy. If we know you're there, you're not going to need us. If you don't tell us you're there, sure as you're going to need to come to the clinic or to the emergency room. So it's just a very positive preventive way to ensure that you and your child have a very nice vacation wherever you're going. Make sure your child wears their medical alert bracelet and necklace at all times. When you're in your home environment, they may not be willing to do that, but you need to impress upon them that this is important when they're out of that home environment. We are traveling more by car in this pandemic age, and so please, please, please do not leave Factor in a hot car. You can put it in a cooler with some ice packs, save some of the ice packs that come when you get a Factor shipment. And if you are flying, be sure you have a travel letter with you. And actually this goes with driving somewhere too, that outlines what the bleeding disorder is, what your treatment is, and who the healthcare provider is with appropriate numbers. Try to keep Factor in its original box. It makes going through security at the airport easier. And don't put Factor in checked luggage. As soon as you put $20,000 worth of Factor in a bag and check it, that's the bag that's going to get lost. So please, please, please be careful. Don't put Factor in checked luggage. And if I had to sum it up, I would say there are two words that really apply to children with hemophilia. One is individual. Everyone is individual. You may look the same on paper. You may both have less than 1% Factor VIII deficiency, but what applies to you or works for you and your child may not work for someone else. And so please keep this in mind, especially if you're participating in chat rooms and things where there are other parents. They may be trying to be helpful and offering advice, but really what you need to do is partnership with your HTC. You don't have to go it alone. In addition to partnering with your healthcare provider, you also need to partner with your child when they understand a little more about their bleeding disorder. Partner with your spouse, with your significant other. You don't have to, and mothers are often guilty of this, thinking they have to shoulder all the burden for their child with a bleeding disorder. Not true. Dads are big helpers. Give them a chance to help you. And reach out to your extended family. It does take a village to raise a child without hemophilia. So this is just an added difficulty. And as I said, please partner with your HTC. Comprehensive care is so valuable. And you and your family are the center of our comprehensive care model. So all of these different people can be available to you should you need them. So just keep that in mind. And if they don't have a dentist or whatever on their staff, they know who they can refer you to. So please use your HTC. Again, you don't have to go it alone. Always keep your HTC's phone number with you, and please have an annual comprehensive clinic appointment. This is a rapidly changing time in hemophilia care, and things change at the drop of a hat. And if you don't go to comprehensive clinic, you're not going to know what these changes are, and they may actually be extremely beneficial to you or your child. And get involved with your local chapter, your local hemophilia foundation, and attend national events like you are here today. And we hope that next year that you'll be able to attend a face-to-face event. So in conclusion, hemophilia is a manageable disorder. It requires teamwork and collaboration, and you need to draw on all your resources, including the HTC, your family and friends, and national organizations. And with that, I'm going to stop and turn it back over to Jasmine.
Thank you, Sue, for that wonderful presentation. So everyone, we do have an evaluation and we would love to hear all your feedback, so please take a couple minutes to fill out our evaluation. And for the remaining few minutes of the session, we'll hold a Q&A in the chat where you will have the opportunity to ask any final questions. And if we're unable to get to your question, please feel free to email your question directly to the speaker using the Ask a Follow-up Question feature. Thank you all for attending and for participating, and please direct your attention to the chat box.